let us move on to treatment of anal squamous cell carcinoma. Most of the questions in your NEET SS, INA SS, your theory questions and Viva questions will come from this chapter, will come from this topic. So the standard of care for cure is concurrent chemoradiation. Okay, okay, remember this. In rest all GI malignancies, it is surgery. But here, the standard of care is concurrent chemoradiation. Historically, even for anal cancers, APR were supposed to be done. Okay, but the results were very poor. All the patients with anal cancer were undergoing abdominal resection. But later on, somebody realized that you can treat this with chemoradiation. And you can cure anal cancers with chemoradiation. So basically it is radiation, but then you sensitize the tumor by giving chemotherapy. Okay, that is chemoradiation. And it is a standard of care in today's era. It is both for early stage and locally advanced disease, and surgery is not the first line. You always give chemoradiation. If the disease doesn't go, then surgery is a salvage. Okay, this is very, very important concept. Initially, it was a Nigro Protocol. Radiotherapy plus concurrent chemotherapy. Radiation was 30 gray and they used to use 5-FU mitomycin C, the original Nigro Protocol. And there was complete pathological response. And this was the landmark trial which told that anal squamous cell carcinomas can be managed by concurrent chemoradiation. Surgery is not needed as a primary modality. Before that, APR used to be done. Okay. With chemoradiation, you have improved locoregional control and you are avoiding stoma in these patients. We don't use induction chemotherapy, it is concurrent chemoradiation. Again, there is no benefit of giving adjuvant chemotherapy. Only concurrent chemoradiation improves disease-free survival. There are various trials like EO, RTC 22861, ACT 1, ACT 2, RTOG and Accord 03 trials. All these have confirmed that the best treatment for anal squamous cell carcinoma is chemoradiation. Previously we used to use Nigro regime, but now we have modified Nigro. What is this modified Nigro? You can use 5-FU with mitomycin C or you can replace 5-FU with Capecitabine. We know Capecitabine is an oral medicine which is equivalent of 5-FU. Oral 5-FU is capacitive. So you can give IV 5-FU with mitomycin C or you can give oral Capecitabine with mitomycin C. And radiation what we give is 50 to 60 gray. Initially it was 30 gray. Okay, now we give 50 to 60 gray or 59 gray. People say around 59 gray. And this 59 gray is given in multiple fractions and per fraction is 1.8 to 2 gray per fraction. Okay, so that's the fraction. You need to know what is modified Nigro regime. If they ask you, tell me what is modified Nigro regime, you should say 5-FU or Capecitabine with mitomycin C. 50 to 60 gray is the total radiation. We give 1.8 to 2 gray per fraction. Okay, so this you need to remember. So I told you 5-FU and mitomycin C is the first line. Instead of 5-FU which is IV, you can use Capecitabine. Okay, Capecitabine evidence, extra trial showed that it is as good as 5-FU IV and it's a widely accepted alternative. The other drug is Cisplatin. It has high toxicity, no survival advantage and not preferred. But if the patient of anal squamous cell carcinoma comes with metastatic disease, you have a patient with anal squamous cell carcinoma with liver metastasis. In that you are going to use 5-FU plus Cisplatin. Patient doesn't have metastasis, then you are going to give 5-FU, mitomycin C and I told you about 50 to 60 radiation. But if the patient has liver metastasis, you will use 5-FU Cisplatin. Okay, this they will ask you in examination, in NEET SS, INA SS. Okay, moment you say anal squamous cell carcinoma, you will tick 5-FU with mitomycin C and radiation. But if they have liver metastasis, then you have to choose 5-FU Cisplatin. Remember that. Okay, IMRT is the standard technique of giving radiation. Okay, it will allow dose calculation and it will spare the normal region like perianal skin, genitalia, bladder, small bowel and pelvic bones. Okay, There is a RTOG 0529 trial. We showed IMRT is better. The one more trial, RTOG 9811. It also said IMRT is better than conventional RT. The radiation fields to be included, you can see here, the red ones are the radiation fields to be included. Primary tumor, mesorectal nodes, presacral nodes, internal and extrailiac nodes, and inguinal lymph nodes. This is where the inguinal lymph nodes will be there, and you have to include those inguinal lymph nodes. Okay, remember, IMRT is the standard technique for radiation delivery in anal squamous cell carcinoma. But remember, there can be locoregional failure in 20 to 30%. Patient can have GI toxicity in 30%. There are a couple of ongoing trials also, and the ongoing trials are aiming at stage adapted therapy rather than generalization. With better radiation techniques, you can achieve less GI, urinary, skin and hematological toxicities without compromising the survival. And remember, IMRT does not compromise efficacy of radiation. There are a couple of special clinical situations we need to be aware of while treating patients with anal squamous cell carcinoma. If the patient is immunosuppressed or if the patient is frail, consider only radiotherapy or consider only chemotherapy. They may not tolerate concurrent chemoradiation. In patients again who have limited life expectancy, you can use mono-agent regimes. Don't have to use dual regimes. Okay, these are the special clinical situations. Is there any role of local excision? I told you the treatment is concurrent chemoradiation. But what is the role of local excision? The indication for local excision, well differentiated T1, T2 lesions which are N0, no node involvement. If you can do complete excision of the lesion, you are able to achieve more than 1 cm negative margin and you can preserve the sphincter. If you can achieve these things, you can do local excision. You do not give concurrent chemoradiation. There is a special type of cancer, that is superficially invasive squamous cell carcinoma of anal canal, SISCCA. Okay, and what is this SISCCA? In tumors, so these are the tumors which have less than 3 mm basement membrane invasion and the maximum horizontal spread is less than 7 mm. So they are basically T1NX, and here local excision alone is acceptable. So in these situations you can do local excision, you need not give concurrent chemoradiation.